Hey everyone, welcome back. I'm Harshal, and I am absolutely thrilled to have you here for part 49 of our series. Today we're diving into a highly requested topic for this masterclass, Evaluation and Management, or EMM, modifiers. If you've spent literally any time in medical coding or billing, you already know that modifiers can be your absolute best friend or your absolute worst enemy. They are the keys to unlocking rightful reimbursement for complex patient encounters, but if you use them incorrectly, they are giant red flags that will immediately trigger audits and just completely wreck your revenue cycle. So today, we're going to master them together right here on Decode Healthcare.
Here's the roadmap for this masterclass. We'll start with the Global Surgical Package Framework. Hit Modifier 25 for same-day services, Modifier 57 for major surgery decisions, and Modifier 24 for post-op care. We'll also cover a few auxiliary EM modifiers, and then wrap it all up with audit defense and compliance.
All right, Section 1, the Global Surgical Package Framework.
Okay, so before we can modify anything, we got to know what we're actually modifying, right? When a provider gets paid for a surgical procedure, that payment isn't just for the time spent cutting or suturing. It's actually a bundled payment. Think of it like a combo deal. It includes the routine preoperative evaluation, the intraoperative procedure itself, and the standard postoperative follow-up care. Now, this bundle spans a specific time frame called the global period, which is typically 0, 10, or 90 days, depending on how complex the procedure is. So your baseline rule is super simple. Routine care surrounding a surgery is already paid for. It is bundled in.
But what happens when things don't go according to plan? That's where modifiers come in. Modifiers are the exceptions to that baseline rule. A modifier is simply a two-digit code added to your CPT code that essentially taps the payer on the shoulder and says, hey, wait a minute, something extra happened here today. They justify breaking out of that standard global bundle to ensure you get correct payment based on payer guidelines. Let's look at our first major exception. It's one of the most frequently used and, honestly, heavily audited modifiers in the entire CPT book.
Section 2, Modifier 25, Same-Day Services.
Modifier 25. You know it, you probably use it all the time. By definition, we use this when a significant, separately identifiable EM service is provided by the same physician on the exact same calendar day as a procedure or another service. Usually, we're talking about minor procedures here, things with a 0-day or 10-day global period. But the medical necessity rule is incredibly strict. That EM service has to go above and beyond the routine pre-procedural evaluation. Oh, and quick side note on CMS billing interactions, Medicare actually restricts billing to HCTPS G2211 complexity add-on code when you've got Modifier 25 appended for a same-day minor procedure, so definitely watch out for that.
Let's see what this looks like in the real world with a correct use case, straight from the guidelines. A patient comes into the clinic for chronic knee pain. The provider does a full assessment and exam of the knee. But while they're there, the patient says, hey, my ear is really killing me. The provider diagnoses otitis externa and does an ear lavage, which is code 69210. In this case, because the provider did a completely distinct assessment, history of present illness and medical decision-making for the knee that had absolutely nothing to do with the ear lavage, appending Modifier 25 to the end code is 100% justified.
But here's exactly what you shouldn't do. The classic incorrect use. A patient comes in with a minor problem, and the provider evaluates it solely to decide whether to perform a procedure. That's it. If there's no distinct additional assessment happening outside of that quick, yep, let's do the procedure decision, you cannot just slap a Modifier 25 on the claim. If you make it an automatic habit without the documentation to back it up, you are begging for an audit. Now, what if the decision isn't for a minor ear lavage, but for a massive life-saving surgery? Well, that brings us to Modifier 57.
Section 3, Modifier 57, Major Surgery Decision.
Modifier 57 is your go-to when an EM service results in the initial decision to perform a major surgery. And remember, in coding, a major surgery specifically means it has a 90-day global period. When your provider evaluates a patient and decides to send them to the OR for a major procedure, either that same day or the very next day, you're going to append Modifier 57 to that EM code.
Honestly, if you only take one thing away from this explainer today, take this little cheat sheet right here. It clears up so much confusion. When do you use 25 versus 57? It literally just comes down to the size of the procedure. Separate EM alongside a minor procedure with a 0 or 10-day global, that's 25. EM resulting in the decision for a major surgery with a 90-day global, that's 57. Lock this distinction into your memory.
Let's look at a scenario for 57.
A patient shows up in the ED with severe abdominal pain. The provider does an exam, checks out the ultrasound, and confirms it's appendicitis. The decision is made right then and there to proceed with a same-day laparoscopic appendectomy. For this, your documentation has to clearly show that the assessment and plan confirmed that initial surgical decision. You'd bill the EM with Modifier 57 right alongside the appendectomy code. Okay, surgery was a success, and we're now in the recovery phase. What happens if the patient comes down with something completely different? Enter Modifier 24.
Section 4. Modifier 24, Post-op Care.
So, Modifier 24 is used when an unrelated EM service is provided by the same physician or someone in the exact same group and specialty during that post-operative global period. The absolute magic word here is unrelated.
Here's a textbook example. Let's say a patient is 10 days post-op from a huge knee replacement. They are squarely inside that 90-day global recovery window. But they show up to the clinic complaining of a terrible sore throat. The provider takes a look, finds strep pharyngitis, and prescribes antibiotics. Well, obviously, getting strep throat has absolutely nothing to do with recovering from knee surgery, right? This is a crystal clear scenario for Modifier 24.
But listen, the documentation rule here is non-negotiable. You have to clearly indicate the visit is not related to the surgery, and you must link it to a totally distinct ICD-10 diagnosis. So patient coming in just for a wound check or post-op pain management, incorrect use. That's entirely bundled. But if they are 2 weeks out from gallbladder surgery and come in with a brand new UTI, boom, that is separately billable with Modifier 24. Now, while 25, 57, and 24 are the heavy hitters, there are a few other auxiliary modifiers you're going to bump into.
Section 5. Auxiliary EM Modifiers.
Let's quickly run through a few more critical ones. Modifier 22 is what you use for increased procedural complexity, basically when a service goes well beyond the norm. Then you have Modifier AI, which is absolutely crucial for identifying the principal physician of record, mostly for admitting physicians during an inpatient stay. And finally, Modifier 33, which is used for preventative care to show that the service gets a cost-share waiver for the patient. Knowing exactly when to deploy these can save your billing team so many back-end headaches. All right, we know the rules, we know the exceptions. Now we get to the most important part of this entire masterclass.
Section 6. Audit, Defense, and Compliance.
How do we actually protect the revenue we've rightfully billed? Well, here are the common denial reasons that will just flat out ruin your day. Obviously, missing the modifiers entirely on a claim is a big one, but auditors are heavily targeting the automatic attachment of Modifier 25 when there's no distinct assessment and plan in the chart. They are also hunting for people unbundling routine post-op visits and cases where there's just a complete failure to support separate medical decision-making. These are the bright red flags payers are looking for.
So consider this your compliance checklist, your ultimate revenue defense strategy. Number 1, always make sure your documentation clearly separates the HPI, exam, and medical decision-making for the EM from the actual procedure. You have to justify medical necessity for every single encounter. Do not blindly stack modifiers without rock-solid chart justification. Also, keep in mind that payer policies are all over the place. CMS handles things way differently than Aetna or UHC, so you got to check their specific rules. And finally, be proactive. Run regular internal QA audits on your high-risk modifiers, especially 25 and 57.
I want to leave you with this final thought today. Take a hard look at your practice's recent claims. Are your E&M modifiers acting as a shield, protecting your hard-earned revenue, or are sloppy coding habits turning them into a beacon that's actively triggering payer audits? It really is time to take control of your coding compliance. Thank you so much for joining me for this masterclass. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.